I'm Alberto Monje, and I will summarize the findings from the surgical and implant-related factors on the onset and progression of peri-implant diseases, which was a systematic review that aimed at providing an evidence-based overview on the prevention of peri-implant diseases for the Academy of Osseointegration, American Academy of Periodontology Consensus Conference that was held in August 14th through 16th in Oak Brook, Illinois, United States. So systematic screening was performed to identify clinical studies reporting on the impact of surgical and implant-related factors on peri-implant diseases. It was interesting to find that 34 articles met the inclusion criteria. However, due to the high heterogeneity across the studies, only qualitative assessment was performed. The clinical evidence available proved that surgical-related factors, in particular, inadequate implant position, and to a lower extent, implant placed in regenerated bone, especially when this fails, are more prone to exhibit peri-implantitis, but not to peri-implant mucositis.
So talking about the other factors that can also influence peri-implantitis and peri-implant diseases, we also looked at implant-related factors. So as Alberto mentioned, this was really a summarized assessment of a lot of the literature that we were able to include in our systematic review. And just to highlight some of the main points and some of the determinants for peri-implantitis onset and progression, we found that implant surface characteristics, such as rougher surfaces, may increase biofilm accumulation, inflammatory risk. Nanostructuring and chemical modifications are on, we're still under investigation. We're looking at the long-term effects. Another factor was implant design and the macrogeometry that we noticed had an influence on the progression and onset of disease, like platform switching and conical connections appear to mitigate crestal bone loss. Wider diameter implants can maybe potentially distribute load better, but have their own challenges if placed too adjacent to teeth or implants. We also looked at implant abutment interface, the micrografts at the connection, which are really potentially really critical for bacterial reservoirs and other material aspects. With regards to implants, tissue, peri-implant tissue, soft tissue integration, like having a sufficient band of keratinized mucosa and favorable mucosal thickness support that can be resistant against peri-implant inflammation. The other aspect we looked at was the implant positioning and how we can prevent future peri-implant disease. We talk about 3D implant positioning, how it's important to place a peri-implant implant properly in the ideal position. Like two buccal placements can increase recession risk or mucosal dehiscence risk. Too apical placement or too deep placement of implants, or such as too subcrestal, may lead to early bone loss remodeling and difficulty in hygiene. And that we want to have an ideal placement positioning, which really should be prosthetically ideally planned. The distance between the implants and the other teeth is also important for us to realize. At least 1.5 to 2 millimeters for teeth and 3 millimeters between implants to preserve the bone and papilla. And then, with depth and angulation as well, which we talked about also briefly. So these are really, really factors that we found both to be clinically making sense and also evidence-based with regards to, the factors that can be influencing the onset and also progression of a peri-implant disease. And I think both maybe Alberto and also Sasha, you can also chime in and talk about maybe your experience as to how that is so relevant into the clinical practice.